All right, good afternoon, everyone. Hopefully everyone had a good spring break. Hey guys, when it's time to start class, we start class. Okay? So we're going to be on the knee today. So what I'm going to expect from here on out, just like with patient care, is that when it's time to start class, we're going to be ready to go, just like we're going to be ready to go for patients, okay? So we're going to move on to the knee. What we're going to cover is a couple class sessions for the knee, and then we're going to have another exam. So exam, remember, is going to cover everything from not only the start of the course, but if you read the syllabus, we can cover some stuff from last semester as well. I won't get too ridiculous with that, I promise. So for example, don't expect high detail brachial plexus questions. All right, so when it comes to the knee, and let's face it, this is a big reason why a lot of us become PTs. This is something that we typically see in the clinic, especially when working sports med, like I've worked a lot in my career. What we have to understand with the knee is that we're going to be dealing with a couple different joints here, just like we saw with the elbow. Now what we're going to see is we're going to see a lot of differences between the elbow and the knee. So the big joints that we're going to deal with here are going to be the tibiofemoral, okay, which literally is just going to be the articulation between the tibia and the femur. We're also going to see the patellofemoral, which is going to be articulation between the patella and the femur. Slash tibia. It's mostly going to articulate with the femur. But as we're going to see, there might be a situation or two where the tibia, or I'm sorry, the patella slides inferiorly a little bit. And then this other one I'm going to put an asterisk next to because it doesn't have a true articulation with, quote, the knee, but it's going to have some attachments and it's going to have some influence on what happens at, quote, the knee. And that's going to be the proximal tibial fibular joint. And that's actually going to be the proximal tibia and the proximal fibula. Now that's going to be one of these similarities that we're going to see with the elbow and the knee. If you remember the elbow last semester, we had that proximal radial ulnar joint, distal radial ulnar joint. We're going to see a proximal tibiofibular joint here and a distal tibiofibular joint, excuse me. The proximal tibial fibular joint is not going to have, like I said, a direct impact on knee flexion or knee extension. But what we're going to see is that structures like my distal attachment to my IT band, my biceps femoris, and my lateral collateral ligament are all going to attach into that head of the fibula. We're also going to see the head of the fibula is going to have a couple big arteries and a big nerve that wraps around the inferior surface. So things like fibular head fractures, and I will tell you that proximal fibular head fractures get missed a ton, especially in some contact injuries with sports and non-contact injuries, that you could be dealing with a potentially life-threatening situation, potentially losing a limb because the vascular bundle around the fibular head gets lost. So just be very, very careful with those. So I'm going to talk about the fibula a tiny bit, and then we're going to move on to the actual knee joint. Okay, so lower leg, and this is going to get into some material in the next section. There's going to be two basic bones, like I said. It's going to be tibia, it's going to be fibula. The tibia is going to be the weight-bearing bone. Okay? So my tibia is going to bear the weight. My fibula is a non-weight-bearing bone. Now, why is that important? I have seen in my career patients walk in, no assistive devices, and they have a fibular fracture. Think about that, okay? So here's your job as a physical therapist. You now have to convince somebody that that person needs an image to screen for a potential fracture. And I had a situation really early in my career where sports scholarships and all sorts of stuff was on the line, and I had to be the person to say that young man's not going to play this weekend. And that was a very tough conversation to have, even though he walked right into the clinic, right? So that's the conversation you're going to have. But you have to understand how those bones interact. You have to understand the relationship in order to articulate that sort of argument, not only to you, not only to the rest of the clinic, not only to referring physician, not only to the athletic trainer, but also to the parents and also to that patient. Okay, there's a lot of people involved. All right, so when it comes to the articular surfaces of the knee, big thing I want to cover here is the differences between the medial and the lateral condyles and the medial and the lateral plateaus. Now, the word condyle equals knuckle. And that's going to be really important to remember, because what we're going to see is that the femoral condyles are going to mimic literally not only my knuckles on my fist, but we're also going to see, and this is a good way that I remember it, all the way down the proximal phalanx, one shorter than the other. And that's exactly what we're going to see with my condyles, is that the medial femoral condyle is going to be much longer than the lateral femoral condyle. That is going to be a huge, important point to remember, because, and think back to that MSK1 question, what's the accessory motion at the knee? And the answer was spin. That's how, right? Because when we have one object that's a different size than another object, and we move those objects in one direction, one's going to stop before the other. If I have one object that stops before the other, it's going to create a rotation. And we're going to see that rotation in the knee. That rotation is going to be called the screw home or locking or unlocking mechanism of the knee. And one point that's a little difficult for this section of material is going to be in different situations, aka weight-bearing status versus non-weight-bearing status. What's moving on what? And am I moving into extension or am I moving into flexion? Okay, so that's going to be one thing that we're really going to dive into, because typically that's one of the toughest sections to remember for this content. All right, so if we're going to look at a toe-to-head view of the femur, basically what we're going to see here this is the exaggerated view, obviously, because I can't draw. This is my medial femoral condyle. And this is going to be my lateral femoral condyle. And the big thing I want you to notice here is going to be the length of the distance. All right, so I have much more length on my medial side than I do my lateral side. The little space down here in the posterior section, this is going to be called the intercondylar fossa. I'm going to circle this one. This one's going to be really important to remember because on respective sides of the intercondylar fossa, that's where my ACL and my PCL are going to attach into the femur. Okay, ACL obviously means anterior cruciate ligament. PCL is the posterior cruciate ligament. Those ligaments are a little different in terms of nomenclature. What we've been used to so far is that my ligaments are named for what bones they attach, right? Okay, and we saw that with things like my glenohumeral ligaments, right, and my acromioclavicular ligaments. Anterior cruciate ligament and posterior cruciate ligament are going to be named based on how they cross, right? So crus or crux means cross. So literally my ACL, or my anterior cruciate ligament, is the one that crosses in front. It's the anterior crossing ligament. The posterior cruciate ligament is the one that crosses in back. It's the back crossing ligament. They say what they are, and they are what they say. Now, the other part of it, we're going to get into this a little later, is that my ACL and my PCL attach to different sections of the intercondylar fossa. Okay, so I want to make sure you understand, because a lot of times, especially as PTs, we figure, okay, that ACL kind of attaches somewhere on the tibia and somewhere on the femur, but we're not exactly sure where. When you guys get into diagnostic imaging next year, knowing exactly where those ligaments attach both to the tibia and the femur is going to be really important, because you're going to hear and you're going to read something called an empty medial notch or an empty lateral notch. And those notch signs are literally going to tell you if the ACL has been compromised, aka an avulsion fracture. Okay, you guys know what an avulsion fracture is, right? So did an avulsion fracture happen to the ACL, or an avulsion fracture happen to the PCL? Okay, so knowing exactly where they attach is going to be really important. But my medial femoral condyle is going to be longer than my lateral femoral condyle. All right, everybody good with this picture? Anybody not good with the picture? Okay. So the other respective part of the tibiofemoral joint, like we said, this is my femoral part that I just drew. The other part's going to be the tibial part. Now, the nice thing about the tibial part is that my medial and lateral tibial plateaus, okay, so my tibial plateaus are going to correspond in size and in shape respective to their femoral condyles. So what we see here, so I'm going to draw out kind of a large, we're going to say this is the entire surface of the tibia, looking down on it. So this would be a head to toe view. And what we're going to see here is we're going to see a longer medial tibial plateau. And we're going to see a shorter lateral tibial plateau. Now, if you ever get confused, if you're looking at the medial side or the lateral side, what I would suggest is out here on the lateral side, this is going to be your fibula. Okay, so there's a lot of times, especially if you're looking at a CT scan, MRI, because remember, a lot of CTs and MRIs, and you guys will learn more about this next year, are going to use the axial or essentially a cross-sectional view. So looking down on it, sometimes you can get turned around, what's medial and what's lateral. And the first thing we're going to do when we start learning about how to look at images is we're going to learn the importance of landmarks. So looking down in an axial view on the tibial plateaus, a really good landmark is going to be that fibula, because you only got one of them and it's only on one side. Good landmark. So what I want you to really kind of appreciate here is the fact that just like with the medial femoral condyle, this medial tibial plateau is going to be longer. And what we're going to see is the structures that are associated with that medial tibial plateau, aka my medial meniscus. Okay, that might be a term you're familiar with from clinic work, is going to be longer as well. On the lateral side, this lateral tibial plateau is going to be shorter. Now, the other thing we have to kind of cover here, and I'll give you guys a second to draw this out, is we're going to start covering a little more convex concave. Now, in the knee, it's pretty darn easy, right? So obviously the knee is going to be a bicondylar, aka two condyle hinge joint, to use layman's terms. So the convex concave rules are pretty simple. The only caveat, if you will, is going to be that screw home mechanism, which we're going to go into. Is everybody good with the picture? Anybody not good with the picture? Okay. All right, so obviously we're going to have a concave surface and a convex surface. So in terms of the tibiofemoral joint, sorry, I'm stuff's on fire again. It's been quite the week. So my concave surface is going to basically be my tibial plateaus. My convex surface are going to be these femoral condyles. So what I want you to start thinking about, okay, and I want you to start applying this to movement. Okay, we're going to get into some functional lab stuff where we're really going to dive into this concept deeply. But from a very superficial standpoint, what I want you to start thinking about is open chain motion and closed chain motion. Okay, so what does open chain mean? Distal end moves, right. What does closed chain mean? proximal end is moving, right? So if I'm performing open chain knee extension, my tibia is moving. Do I have convex on concave, or do I have concave on convex? Concave on convex. Roll and slide, opposite or same direction? Same direction, okay? Give me an example of an open chain knee extension exercise. Right? Okay, this looks like going to the clinic, going to the gym, leg extensions, right, or knee extensions. Okay, that's an open chain motion. What's an example of a closed chain knee extension motion? Squat, transfer, sit to stand, right? So what you have to understand, and this directly relates to your patient, right? So you have that patient, they had a total knee done. I want that patient to start exercising, aka training, sit to stand transfers. Are they going to fully be able to do it? Yes, no, maybe. Maybe, we don't know. But what I have to understand is, with that total knee patient, I then need to do a joint mobilization on them, right? Let's say they can't do it. Or let's say they're lacking 5 degrees of full extension or whatever it is. And if I'm going to do a joint mobilization on them to increase their knee extension, what do I need to do as a therapist? Say it louder. Inferior glide? No. Okay. Posterior of what? Tibia. Posterior tibia? Okay, let's think about it. Okay, so I appreciate you speaking up and answering. Convex, concave. Okay, if my tibia is moving into extension, roll and slide are the same way. Okay, if I'm doing a joint mobilization on the patient, am I going to affect the roll or the slide? The slide. Okay, so if I need to increase extension, I need to perform an anterior mobilization to the tibia or a posterior mobilization to the femur. Okay, do you understand why? Okay, so the femur, roll and slide are opposite. So this is why, if you guys are ever in the clinic and you saw the therapist, all right, patient, let's lay down on the table, and they're they're performing CPR to their knee, right? Who's seen that? Right, they're sitting there, they are just cranking on that knee. What they are doing is typically providing a posteriorly directed force to the distal femur to increase extension. Okay, so that's going to become a point you're going to hear over and over and over again throughout PT school, really understanding where to direct that force. Because if you're trying to increase extension on a patient and you provide a posterior directed force on their tibia, what's going to happen? A whole lot of nothing, right? Because the arthrokinematics dictate that the posterior directed force needs to be on the femur. Okay, so you have to understand how the arthrokinematics work here. All right. Any questions on that? No.
What did you say about the one was anterior and one was posterior?
I'm not sure what you mean.
I think you were talking about the slides, like something for the tibia that I think was anterior.
So tibia is going to be anterior, right? Because that's going to be the concave surface. Mm-hmm. The femur is going to be posterior because that's going to be the convex surface. All right, so that's going to be the tibiofemoral joint. All right, any questions about tibiofemoral joint? We'll do more on this later, but I want to get on to patellofemoral joint. All right, so the other joint we're going to have here that's going to directly relate to the knee is going to involve this little gray bone called the patella. Now, the patella itself is going to be a sesamoid bone. You guys remember what a sesamoid bone is? It's a bone just kind of floats inside of a tendon, right? So you guys remember the pisiform from last semester? That's a sesamoid bone. The patella is going to be a really, really big sesamoid bone because the patella is going to be completely encased in something called the quadriceps tendon. So this is a big reason why, if you guys have ever done this, either on your own or seen it done in the clinic, you can actually take that patella and you can move it all over the place when the knee is in a certain position, right? Because there's really no firm attachment for that patella. So I'm going to redraw in the femoral condyles here, and we're going to draw in where the patella articulates. Okay. Okay, it's being lateral, medial, anterior, posterior. And that is our so where the patella is going to sit is going to be in this little section here. And this little section here is called, literally, the Patellar Groove. The interesting thing about the patella is that, like I said, it's going to sit not necessarily right up against the bone, but it almost has this kind of triangular look at it, or look to it, if you look at it from bottom up, or if you cut it in half. And that's really important as well, because with the patella, what we have to think about is that I have a whole nother convex and concave surface. Okay, and this is where things get a little tricky. So before we get into that, what I want to get into is why we even have a patella. So like I said, the patella is encased completely in the quadriceps tendon. The reason I have a patella is all literally leverage. You guys may go over this in biomechanics with Dr. Fox, but it becomes very important because the patella provides a really nice moment arm for my quadriceps tendon. And the reason that's important clinically is you may encounter a patient, and I have encountered this patient, where they don't have a patella. The patient that I saw, their patella was traumatically removed. So what we have to think about is if that patient does not have a patella, what the impact is going to be at the knee. So what do you think the impact at the knee would be if that patient doesn't have a patella? Yeah. So they're not going to have nearly as effective knee extension with the same quadricep muscle. So we actually had to clinically like super bolster this guy's quadricep on the involved side. Like it was like an inch thicker on the involved side than the uninvolved side, because we had to account for, and we had to hypertrophy the involved side to account for the bad leverage he had, or the bad momentum. Yes?
Where did they insert the quadriceps in the
They well, he, like I said, he traumatically removed his quadriceps. It got blasted to pieces. That's serious. So what they did was they took all of it out. They reattached the quadriceps tendon down to the tibial tuberosity, because that's where the quadriceps tendon attaches anyway, and they literally just screwed it in. Yeah, you guys will see some stuff. So, like I said, we had to hypertrophy this guy's patella, or I'm sorry, his quadricep to make up for the fact he didn't have a patella. I was amazed with how much we had to. I mean, this guy was 4 out of 5 for about 9 straight months. And we just had to sit there and just crank and crank and crank to get his quadricep larger. Okay.
Unilaterally.
Unilaterally. He only had one blasted off, luckily. All right. So like I said, this all kind of filters in regards to the difference in size between the medial femoral condyle, medial tibial plateau, lateral femoral condyle, lateral tibial plateau, into the movement of the joints. Okay, so like I said, basic arthrokinematics, the knee's going to have 2 basic motions, right? It's going to have flexion, and it's going to have extension. No big deal. We expected that out of a knee. Obviously, with flexion and extension, that can occur in a couple different ways based on if my patient is weight bearing or non-weight bearing. I will highly recommend, for testing purposes, aka exam stuff, highlight whether or not they are weight bearing or non-weight bearing, because the weight bearing changes the game completely. Okay, and I don't want you guys to get turned around on test questions because you forgot their weight bearing status. So I would highly recommend using that highlighter function on Exemplify and highlight immediately if they're weight bearing or non-weight bearing. So because your thinking should completely change. So basic motions I'm going to have here at the knee are going to be flexion and extension. Obviously, we talked about that can be femur on tibia or tibia on femur. The other motion I'm going to have here is going to be a tiny bit of rotation or spin. This rotation or spin directly refers to something called the screw home mechanism. Now, the screw home mechanism is only going to take effect, or only going to happen, in the range of 0 degrees, aka full extension, to about 30 degrees of flexion. Okay, so it's going to happen in 0 to 30. The other thing, guys, I want you to really watch out for on test questions is what motion's happening. Okay, and this is going to become a really big point, because what I want you to think about is, and I'll give you an example. Okay, am I in flexion or extension? Okay, Am I in flexion or extension? I'm in flexion. All right, okay. So flexion, cool. Flexion, cool. But what did I do there? I extended. Okay. So what I want you to think about is when I'm, quote, in flexion, that's everything from 1 degree of flexion all the way up until 140 degrees of flexion. That's in flexion. Think back to when we did this for the shoulder way back last semester. And I said you have to really differentiate the ION suffix versus the ING suffix. You guys remember that? Kind of, sort of, not really? Okay. So this is going to become very important because my screw home mechanism is going to have 2 basic phases. It's either going to have a locking phase or an unlocking phase. Okay? So I have 2 phases. I can either lock or I can unlock. When I'm locking the knee, that means I'm extending to full extension. I may not get there, that's my goal. When I unlock the knee, I am flexing. And this becomes confusing because when you're dealing with problem sets and test questions and things, you have to consider weight bearing status. Cool, right? Because, as we already talked about, if I'm non-weight bearing, my tibia is moving on my femur. That means my femur is not moving. Okay? When I'm in a weight bearing status, my femur is moving on my tibia. My tibia is not moving. Okay, and I know I'm belaboring this point, but I want you guys to understand it. So here's what I want you to think about. If my patient is performing knee extension, open chain, this guy, right? Here's what happens. From 30 degrees to 0 degrees, the lateral tibial plateau runs out of space. We talked about that. My lateral tibial plateau is smaller than my medial tibial plateau. As that bone continues to move, the lateral tibial plateau stops. And the medial tibial plateau keeps going. So you have literally lateral tibial rotation. Okay, so my tibia rotates a tiny, tiny bit, so I'm about 5 degrees laterally. Okay, so open chain, knee extension from 30 degrees flexion to 0 degrees. My medial tibial plateau continues to do its thing, its slide, and that results in a tiny bit of lateral rotation to the tibia. Okay? This is one of those things where, and I think what I'll do is I'll get the bones, and we'll take them down to the functional lab, and we'll play with it so you guys can see. There's also YouTube video on my YouTube channel that I made when we first broke for COVID a couple years ago, where I literally take the bones and you can see it. I will say, because it's such a, and I'm not tooting my own horn about this, but because this is such a tough topic, that video has probably more views than all my other videos combined.
Does anybody in here have ulcerative colitis disease?
Ooh.
Okay, so you feel like you have a big knot right there. You can see this on yourself. You can literally put top of the pin right there at that bony prominence, one on your patella. And when you extend your knee fully, you can see those two dots go whoop, and disalign with one another. I say somebody because their sliders too, because that plateau where the patellar ligament at that point is really only patellar tendon until you get to the section point on the patella itself. Anyway,
My athletic trainer, she had to tape mine, so it would not.
but particularly if you've got that, again, you typically have that really prominent tibial plateau, and you can see it. You can see those dots disalign as that lateral rotation of the tibia actually happens.
And we're going to do that in functional lab. Yeah, so we're going to ink each other a little bit just so you guys can see that mechanism. Okay. Now, why is this important clinically? Right? This is not just about answering test questions in anatomy. I know. Here's my patient. Hi, patient. My patient's lacking 5 degrees of extension. Doc's on the phone, they're screaming, yelling, why does my patient have full extension? It might be because of this screw home mechanism. So who in the clinic has seen that therapist and they're yanking on one side of the tibia or they're pushing on one side of the femur to get that full extension? If those condyles and those plateaus are equally sized, I should push on both sides to get extension. But what happens a lot of times is either through joint effusion, edema, scar tissue, whatever, sometimes you can lose that last 5-10 degrees of extension, and you actually need to push into rotation to enhance or help that screw home mechanism. Okay? So again, open chain, knee extension. Last 10 degrees, tibia is going to laterally rotate. Cool? All right. Now, I'm going from 0 degrees extension down to 30 degrees. I'm flexing my knee in the open chain. That lateral tibial plateau doesn't change shape or anything. It's still going to hold tight. My medial tibial plateau is going to start sliding first. So if that lateral tibial plateau is holding tight and my medial tibial plateau is sliding, what I will see with open chain flexion from 0 degrees to 30 degrees is medial tibial rotation. Okay? So lateral tibial rotation with extension, medial tibial rotation with flexion. All right, I'll tell you what, let's take a 5-minute break, and then we'll go on to what the femur does. What's that? No, I just started wearing glasses.
You said
Yeah.
medial tibial rotates laterally with knee extension,
Lateral, yeah, with open chain knee extension.
and with open chain knee flexion, it rotates
Medially.
medially.
Yep.
Okay.
Yep. Hey, how about your grand slam yesterday?
Yeah.
Yeah.
All of it.
I saw a video.
First pitch after the pitching games too.
That's the best time to hit.
Yeah, they brought in a lefty for the lefty on lefty matchup, I guess. First pitch.
I never believe in righty versus lefty. I think it's a both garbage. I do. And I mean, let's face it, that's a good pitch to swing at because that guy wants to start with the strike.
Yeah, you try to get me over slider first pitch, just hung it right over the middle plate.
Good for you. Now, did you bat flip and like, do the whole thing?
I didn't bat, no, I didn't bat.
I'm kidding.
No, we were ahead by like 5. If it was a little bit closer, maybe. Yeah, give the dugout a little look, but.
Probably best you didn't. You might get one in the ear next time up. Yeah. I don't care. 89 hurts. 91 hurts. The hardest I've ever taken was 88. That hurt. Yeah.
We had 2 guys get hit in the face.
Really? Wow.
Yeah. So.
That's scary.
One guy didn't have anything, just bad bruising, but the other guy could really help him out.
I can imagine. I'm kind of surprised they haven't gone to the face mask like they do in softball.
Yeah, so actually, they call it seat flags. Yeah, it's just a flag that comes off the side.
Scary.
Yeah, it was against the same team.
Really?
Yeah.
Ooh. Ooh.
They were both against
What's up?
Do you mind repeating that last part? Medial tibial rotation flexion.
This is magic. I was going to do this anyway. This is going to be fun because then people are going to walk into class and go, oh my God, I missed something.
actually not that.
No problem. No problem. The beat's repeating it 18 times. It's also why I like recording the lectures. Like, you miss it?
That's all I hear.
What's that?
That's all I hear.
It's what? Oh.
Holmes makes fun of me too.
I looked over. I had to say that concept was Tommy was like.
I made an egregious error today. Today is International Pie Day, and I have a pie tie. I did not wear my pie tie. No. No, it's called, what's the term I'm looking for, next year. Yeah. This is the first time in my time at Methodist that we had a National Pie Day during the week. You've only been here 3 years, it's been Saturday and then Sunday. Yeah. I missed opportunity, I did. The Fayetteville Pie Company? Yes, and actually, it is over by the mall. So not Skyville, but like Morganton Road. They may. They may. Do you know where that like the Battle House is? You can see it like off All American Freeway. Okay, it's in that little mall. It's Yes. Yes. I have to limit myself when it comes to things like that. Yeah. Neither do I. Something tells me I can probably put away more than you. Interesting. Interesting. Oh, that's my son. My son is 6 foot 115, and he put down like 2 gallons of ice cream. Yeah, that kid can freaking chow. It's I mean, like he is my height, this big around. Yeah. Mm-hmm. Yep, we all got our thing. We all got kryptonite. So in Raleigh, there's a crispy, there's a run. Yeah. You run half, you eat your donuts, you run back. You always say, watch your step on the way back. All right, so what I've written up on the board is the cut down easy version of open chain knee extension and flexion in terms of rotation. Please just understand what's moving on what in open chain. Obviously now we're going to move on to the closed chain. So closed chain, aka weight bearing, aka my femur's moving on my tibia, the same rules are going to apply. But what we just have to watch out for is the arthrokinematics. Okay, so like we talked about, my femoral condyles are convex surfaces. Okay, that's a huge point to remember. Remember, my femoral condyles are convex surfaces. So here we go. So on my patient, all right, patient, we're going to do some mini squats. Sweet. All right, so I'm moving from 30 degrees of flexion to 0 degrees of flexion, aka I'm extending my knees. Cool? Yeah. Remember, lateral femoral condyles are shorter than medial femoral condyles. So here's what happens. As I extend, lateral femoral condyle runs out of space. Medial femoral condyle keeps going. So as I'm flexing, as I'm extending, that medial femoral condyle is going to continue to spin. It's going to create a rotation. So my medial femoral condyle slides and slides and slides backwards, posteriorly, causing medial or internal rotation when I'm extending. Okay? So if I am in a weight-bearing status, aka closed chain, and I'm extending, I'm going to see medial rotation. If I am flexing, and I'm moving from 0 degrees, standing straight up, and I'm squatting down to 30 degrees, lateral femoral condyle still is going to hold tight. Medial femoral condyle, as I'm flexing, is going to start moving and sliding, causing lateral rotation. Okay? This becomes a little difficult because you know what's going to happen. You're going to get a test question, and it's going to say, you know, a 65-year-old, blah, 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 and the therapist trying to work on blah, blah, blah. What direction should they push the femur? You're going to go, I don't know. What are my options? And you're going to look at the options. It's going to say medial rotation of the femur, lateral rotation of the femur, lateral rotation of the tibia, medial rotation of the tibia. And you're going to go, oh, come on, Conda, that didn't help me at all. Like, where's the none of the above, right? So, yes?
At what point does the spin start? Is it 30 degrees?
30 degrees.
30?
Yep. So, open chain, flexion, extension, 30 degrees of flexion to 0 degrees if I'm extending, 0 degrees to 30 degrees if I'm flexing, same thing with closed chain, 0 to 30. After 30, the lateral tibial plateau and the lateral femoral condyle start sliding and kicking in, and then everything just moves like it should. Okay, so everything starts moving evenly. This is only in that 0 to 30 sweet spot. Okay, this is a big reason why you see these patients with ACL tears, and you get all sorts of flexion back or all sorts of extension back in the first couple of weeks, and then the therapist is sweating bullets for over the next 4 weeks because they can't get the last 5 degrees or the last 10 degrees. A lot of it is because of the screw home mechanism. Because let's think about it. If my patient is lacking 10 degrees of extension and the therapist is pushing evenly on the lateral and the femoral, lateral and medial tibial plateaus, are they really providing the most effective treatment? No. They should be pushing harder on that medial side because it has more room to slide. This stuff is actually going to help out your career a ton because remember, if you're working in a busy outpatient clinic or a busy sports med clinic, you're going to have to do this 14 to 16 times a day for the next 80 years. Right? I mean, I'm in year number 20 in my career. Trust me, it takes a toll on you. That's why my thumbs look the way they do, because of arthritis. You guys never noticed that before, did you?
So for extension, is there lateral condyle shorter?
Can you say it one more time?
So like if you have hyperextension of your knee, is your lateral condyle shorter than?
Not always. Sometimes there's a genetic defect to the bone. A lot of times what it is that the posterior capsule is really loose or the PCL is really loose. But good question. Yeah, so it's not, this is only speaking to the bone. Okay. Any other questions about screw home mechanism? I want you to really, especially when we get into functional lab, when we get into some of the other stuff we're going to cover in this section, I really want you to know this because this trips up students every single year. Okay? No pun intended. Somebody got it. All right, so moving on to some of the soft tissue that we're going to see in the knee. Menisci is plural for meniscus. Okay, and all a meniscus is just that very outer edge. Okay, and that's literally all a meniscus is. So lucky for us, the lateral and the medial menisci are going to follow the lateral and the medial tibial plateaus. Okay, so my lateral meniscus is going to be shorter and my medial meniscus is going to be a little longer. Now, what I want to direct you to is that picture right up there. And here's why. So I said medial meniscus longer, lateral meniscus shorter. That's going to mimic or follow their respective tibial plateaus. One thing I really want you to watch out for is the amount of space in the weight-bearing chamber. Because remember, that view that we're looking at where I drew the arrow, that's a top-down view. My femur is going to sit right on top of that, right? Cool. My lateral side is going to have much more meniscus coverage under that femur than my medial side, right? There's more open space there. Look at that amount of open space versus here. Look at that amount of open space. Now, why do I care? I care because what's not there? I don't have meniscus. Protection. Why do I have a meniscus? What's the purpose of my meniscus? Looks cool? What's that? Stop friction? It can reduce friction. Yes, it can definitely reduce friction, because I would argue that a nail about that long would stop friction. Fair? Okay, so we're going to reduce friction. And that becomes a really, really big point when my meniscus goes away. Right? When people shred their menisci because they like to do weekend warrior stuff, or they like to run around, or they like to lift super duper heavy weights, or just because that's how they are, they shred their meniscus. Well, what happens when I shred my meniscus? What am I not able to reduce? Friction. So then what's rubbing on what? My femur is rubbing on my tibia. What happens when a bone rubs on a bone? What force do I cause? Friction, shear. She wasn't looking. Right, so I'm going to cause a shear force. After I start shearing off the synovial lining of those bones, what process am I going to start? Osteoarthritis, osteophytes, right? What's an osteophyte? It's a little overgrowth of bone, isn't it? Okay, who has calluses on their hands? What's a callus? It's overgrowth of skin. What is a callus representative of? Why does someone develop a callus? Hard work. Okay, I'll go for hard. You know what? I'll go for that one. I'll go for that one. So what about hard work causes me to have a callus? The friction. The friction, or the shear force of my hands on a tool, right? So hard work, I think you're referring to manual labor. Okay? So my hands up against a tool, or my hands up against an item, cause a shear force. What's the first step in that process? Who here has done a bunch of yard work and sheared the skin off their hands? Yeah, or a blister, right? So shear all that skin off. It hurts, it's sore. You don't want to do it the next day. What happens when you do it over and over and over again? The skin starts to build up, doesn't it? The same process happens with osteoarthritis. I shear the synovial lining off. I start shearing the periosteum. My body goes, that sucks. I don't want this. I don't want part of this anymore. So it starts laying down the material that's already there. For my hands, that's skin. For my knees, that's calcium. Okay, so I start laying down all this extra calcium, and it lays down in these jagged, horribly organized patterns called osteophytes. Well, what do you think happens when I have a bunch of jagged edges rubbing up against a bunch of jagged edges? Does my shear force go up, or does it go down? It goes way up. Okay, so what's my body do? Also, well, that sucks. I'm going to lay down some more of that. Body ain't too smart. Okay, I'm just going to warn you. Like, that's why I have a brain. All right, if it was just up to my body, then forget it. So it starts laying down more and more of this calcium. Osteophytes grow bigger and bigger and bigger. Shear forces get larger and larger and larger. And then we have degenerative joint disease. Then it's time for a knee replacement. So reduction of friction is definitely something that my meniscus does. What's something else my meniscus does? Shock absorption. Tell me about that. You're going to answer me, says what it is, as what it says?
If you look at the second picture,
Absorb some of the weight, the force of your weight coming down into the tibia.
Okay, so what's another word for absorb? Disperse, right? So what is dispersion? Yeah. Meniscus. What's the meniscus made out of? Cartilage, right? So when I bear weight, my femur compresses down onto my tibia. My meniscus takes that force and spreads it over a wider area, right? That's dispersion of force. So that's something else that my meniscus does. What's something else my meniscus does besides looking cool and giving me job security? Okay. I'm gonna go for this one. It increases joint stability / congruency. Okay, take a look at this picture down here. How are those menisci shaped? Like a big triangle, right? I have a meniscus here. I have a meniscus here. I have this huge femur sitting down on top of it. Tibial plateau is a very, very straight, very flat, almost all plane. That's why it's called a plateau. That's why it's not called a cup. So what my menisci do is they provide a little bit extra. I equate this to the bumpers when you're bowling, right? Just a little bit extra, like a little something just to kind of help the effort. Not saying you guys need bumpers when you bowl. I still do. But it provides a little bit of extra congruency. This is the same concept that we saw way back when in the shoulder, right? You guys remember the shoulder labrum, that glenohumeral labrum or glenoid labrum? Why was that glenoid labrum important? It just gave a little hug, right? Just gave a little bit extra congruency to that joint. Same thing is going to happen here. That meniscus, because it provides a little bit of a bank, provides a little bit of a edge or border, is going to really help the arthrokinematics. Because literally what it's going to help do is going to help enhance the roll aspect. Okay, think about that. You know, for the person who's holding the bones, you are. Okay, hold up that tibia. Hold it that way. So I can see the plateaus. The plateaus? Yeah, okay. Show it to the entire class. Okay, take a look at those plateaus. Those are really flat surfaces. All right, now hold up the femur. Okay, so everyone can see the condyles. The inferior side of the condyles. Perfect. Look at those guys. Those are really flat surfaces. So here's how dumb the body is. Okay? Now I'm going to make a baseball example here. Don't take offense to this. The worst thing about baseball is you take a round bat and your round ball and you tell the player to hit it square. Right? Dumbest thing ever. Right? Don't tell me that's wrong. I mean, come on. It's like, oh, hit it square. It's like, what? How do I do that?
that's why baseball's so beautiful.
Oh, I agree. I agree. But I'm taking a flat surface on a flat surface and I'm saying, just roll. right? Cool, just roll with it. If I don't have those menisci, all I'm going to get is slide. I'm going to get a ton of slide. So that's what my menisci are also going to do, is increase or enhance or improve the roll portion of arthrokinematics. What?
I was not anticipating a bone come flying in like this. especially-
Hey, this is PT school. You got to be prepared for everything, right? Here's the other thing. This is the fourth thing my meniscus is going to do. And this is going to relate back all the way to point number 1 here. It is going to lubricate this joint. One thing that I'm going to ask you guys to do in cadaver lab is cut open one of those knees. And I want you to take your finger and I want you to put it inside the knee joint. And I want you to get a little bit of synovial fluid on there. It literally feels like olive oil. And I want you to rub it between your fingers. Okay? Who's heard the term motion is lotion? This is where you're going to see motion is lotion. Okay? Because movement, exercise, will enhance or stimulate the production of synovial fluid. Here's what you guys got to think about. Okay, that patient's going to come in. They're going to be in your clinic. It's 8 o'clock in the morning on a Monday. You're running late. Kids wouldn't get out of bed. Not my life at all. And you're going to go in and do the eval. First patient, stage 4 degenerative joint disease. Here's what that patient's going to tell you. You can't do anything for me. I have arthritis. Right? Who's heard this one come out of someone's mouth in the clinic? Yeah. Here's what you get to do as a therapist. You get to say, I can do something for that. Please phrase it in more professional terms than that. But here's what you're going to have to convince that person of, is that you can actually do a lot for them, because we are going to stimulate the secretion of hyaluronic acid, aka synovial fluid, which is going to lubricate the joint. And at the beginning, it's going to hurt. It's not going to feel too good. It's going to grind. It's going to not feel good at all. But I need you to have some faith in me, because if you do what I asked you to do, your knee's going to be a lot better off afterwards. And even if you do need the knee replacement and end up getting it, you're going to be stronger after surgery, right? So it's all win-win. But we have to understand how that process works. Okay, any questions about menisci? Okay, fantastic. All right, next point is going to be the joint capsule. Now, the joint capsule itself in the knee, and you guys are going to see this in the cadaver lab, it's thick. It is a very thick capsule. Because of the weight-bearing component of the knee, it's going to be thicker than what you guys saw on the elbow, even though there's a lot of relationship between the knee and the elbow. So be ready when you guys are in cadaver lab that you're going to have to do some cutting to get through that capsule. We already talked about the concept of open pack and closed pack positions. Okay? So the closed pack position for the knee is actually 2 different positions. Number 1 is going to be full extension. Number 2 is going to be full flexion. And this is why. If I draw in, this being my femur, and this being my tibia. That joint capsule is going to encompass this whole area in between the femur and the tibia. What I have to understand, and this is the reason the closed pack position is actually two different positions. When I'm in full extension, as we can see from the picture up here at the very top, the posterior capsule is being stretched. In full flexion, the anterior capsule is being stretched. Now this is important, okay? Because if I'm that therapist and I'm doing joint mobilizations on a person, and I put them in full extension, and I try to start sitting there and just cranking and cranking and cranking on their knee, I'm going to run into the capsule, the posterior capsule. I'm going to do a whole load of work and not get a ton of result because that capsule is thick, like I said. Remember, you're going to do this 14 to 16 times a day for the next 100,000 years. I know what student loan interest rate looks like. Mine's sitting at 9.9. I don't know where you guys are sitting at. What's that? That's about right, isn't it? Yeah. So if I'm in full extension, posterior capsule is going to be stretched. If I'm in full flexion, anterior capsule is going to be stretched. The sweet spot, the open packed position, and I'm going to write this down. I'm going to write down here in the corner. It's going to be about 25 degrees of flexion. And at about 25 degrees of flexion, the anterior capsule is on some slack and the posterior capsule is on some slack. Now that's going to become really super important, not only for joint mobilization, but also for testing those internal components of the knee. All right, we already talked about ACL and PCL. Where do those ACL and PCL ligaments sit? Inside the knee, right? They're internal to the capsule. So I got a patient coming in. They have direct access. Means they don't see a doc first. They come in and see me first. Hey, I was playing basketball over the weekend, felt a huge pop on my knee, and it doesn't feel right. I then need to test the integrity of their ACL. Who in here has had their ACL tested? How did they test your ACL? Did they put your knee in a little bit of flexion? Why? To put the capsule on slack. Because I can yank on that ACL and I can yank on that PCL until the cows come home in full extension, and all I'm doing at that point is testing the capsule. I'm not testing the actual ligament. In order to test the actual ligament, I need to place the knee in about 25 degrees with the flexion. If I'm testing the ACL, because what we're going to learn here on Wednesday is that the ACL is going to control anterior translation of the tibia. So if my ACL controls anterior translation of the tibia, in order to test it, I need to perform anterior translation of the tibia. Right? So this is why, for those of you who had your ACL tested, athletic trainer, physician, PT, whoever it was, grabbed your tibia and yanked it forward. If there's a ton of motion there, that means the ACL has been compromised, either partially or totally. If there's really no motion there, or very little motion, or the motion's equal, uninvolved side versus involved side, ACL is okay. Now PCL controls posterior translation of the tibia. So in order to test the PCL, you grab the tibia and you push it backwards. And if there's a ton of motion going backwards, that means the PCL has been compromised. Okay, we'll get into that a little bit on Wednesday. All right, very good, guys. I will see everybody in lab, or I won't see you in lab.